So good morning, good afternoon, and good evening, everyone. I just want to make sure that we have broadcast to all our participants. Just give me 1 second. We have, excellent. We have currently 42 participants. Apologies for that short delay. So good morning, good afternoon, good evening, everyone. I'm Olive Kokeman, and I am supporting today's webinar hosted by the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Thank you for joining this second webinar in the series. The series is titled Lessons for Improving Quality of Care During COVID-19. This is a series organized by the Network for Improving Quality of Care for Maternal, Newborn, and Child Health and the World Health Organization. We started this series because what we've seen over the past months is a lot of discussion and reflection on the struggle to maintain access to essential services and to maintain the quality of care in these services for maternal, newborn, and child health. But what has been evident are so many examples of adaptation, adaptability, and improvement. And this is what we really wanted to share. We have teams of quality improvers that are analyzing problems, going through the QI cycle of testing solutions to these problems as they go. So this series is dedicated to their learning during this unprecedented pandemic, COVID-19. Today, we have 2 excellent cases to share of lessons learned, one from India and one from Bangladesh. So in one moment, I'll hand over to my colleague, Dr. Rajesh Mehta, the Regional Advisor for Newborn, Child, Adolescent Health in WHO's Regional Office for Southeast Asia. And he's going to introduce the overarching themes from the region during this pandemic, and also our panelists today. So the final talking point is just to explain how this session will go. We have 2 parts. In the first part, we will hear from the region and the 2 countries, and we will have 2 presentations, firstly from India and then from Bangladesh. And then in the second part, we really want to hear from you. We want to hear your questions, and we will engage in a discussion with panelists and develop that conversation together. So please type your questions in the chat box during the webinar, and my colleagues and I will curate those questions. And we leave 20 minutes at the end for the speakers to answer those questions and have this discussion. And by the way, we are recording the session, so we will send you that link tomorrow with the recording and the presentation. And so now I give the floor to Dr. Rajesh Mehta. Dr. Mehta, please.
Yeah, thank you, Olive, and good morning, good afternoon, good evening to all colleagues who have joined today with us. So, you know, we are in that strange period of our lives when COVID pandemic has hit us hard. Until yesterday, WHO had the reports of 67 million, more than 67 million new cases, and 1.5 million, more than 1.5 million deaths. And in Southeast Asia region, which is 3rd in rank in terms of burden of new cases, more than 11 million cases reported until yesterday. And within the region, India being a very big part of the population, standing in 2nd rank worldwide after America. So we have still a huge number of new cases going on. And as was seen, the pandemic itself has stretched the systems. These systems which were well endowed, like in Europe and America, they have suffered, and even in low middle income countries even more. So the emphasis, the work for the government has been to restore the health system and continue to provide the essential services for women, newborn children, and adolescent, which is a big job presently. So we did map some of the situation in the region in all 11 countries, and we found there is both disruption in quantity of services as well as quality of services, because the health workforce from our area of work, which is MNCAH, has been moved to COVID-related work. Some essential supplies have got affected. The people are not reporting to labor rooms or the pediatric OPDs, and therefore there is disruption in services. And since we have shortages of people, even the quality of care is suffered. So the first important priority for the government was to immediately start some clinical based trainings because the new things had emerged. So they continued to invest in clinical training on COVID positive cases, but also trainings on infection prevention, how to protect yourselves, the health workforce by using personal protective equipment, etc. And before the COVID pandemic hit us, our countries, both Bangladesh and India, who happen to be the network countries from Global Quality, Equity, and Dignity Network for quality of care for mothers, newborn children. So much was going on, and they had to adjust to the pandemic situation. And there were two shifts which happened immediately to our quality of care work. One was that the teams who were doing quality improvement for mothers, newborns, and children shifted their attention to COVID-related work. So we will see some examples from today's session, especially from Bangladesh, that how did we introduce new content in our quality improvement work. The other thing happened in terms of using the digital highway. Digital pathway is the future, and it is going to stay beyond the COVID pandemic. And we see that many of the activities of quality improvement have started using digital, replacing the face-to-face contacts and on-site work. So we will hear that block of work from India. So therefore, we thought in this series, let us talk about how the situation changes and how the systems make adjustments, and how particularly WHO and UNICEF and other partners are in this journey to support the governments and the health workforce in the countries to change course, adapt new things, and deliver good quality care and restore the services which have been disrupted. So it's my pleasure to first bring in India, and Dr. Deepti Agarwal, who is the National Professional Officer at WHO India office, will take over from me at this stage. Over to you, Dr. Deepti.
Thank you, Dr. Mehta, for the introduction. Before we go on to hear in detail about the digital innovations from the Nationwide Quality of Care Network, I'm glad to share a few examples of the innovative ways in which quality improvement initiatives for maternal and newborn care have continued in India during COVID-19. And as Dr. Mehta just shared, I think the shift has been in both the directions, adopting the digital platforms as well as making a shift for adopting quality improvement approaches for COVID-19 response. So before the pandemic forced the national lockdown in March, the All India Institute of Medical Sciences and the Nationwide Quality of Care Network in India were leading the national mentoring group for Lakshya, which is the labor room quality improvement initiative of the Ministry of Health. They were providing in-person support for coaching and mentoring to the QI teams at the teaching hospitals and at the district and sub-district health facilities in 15 states in partnership with the state health missions. And as you've just heard, just following the lockdown, the Ministry of Health took the first step towards setting up an online platform to train thousands of health workers in infection prevention and control measures, as well as managing COVID-19 cases. And as they say, out of adversity comes an equal or even a greater opportunity. The WHO Collaborating Center for Newborn Care at All India Institute of Medical Sciences already had an effective online presence, offering training programs for newborn care and point of care quality improvement through their online platform. They capitalized on this opportunity by launching an online training program and a mobile app for facility-based care of preterm infant, with an aim to eliminate retinopathy of prematurity by improving quality of care. Since the launch, more than 4,600 nurses have enrolled in this course, supported by more than 70 newborn experts from across India as mentors. Meanwhile, the WHO Collaborating Center for Reproductive Health at the Department of Obstetrics and Gynecology, again at the All India Institute of Medical Sciences, not only continued their online support for coaching and mentoring to the network hospitals, but very importantly, they also applied the quality improvement methodology to organize obstetric care for COVID-19 suspect or asymptomatic pregnant women. They have recently published their work in the American Journal of Medical Quality sharing the experience of setting up a COVID-19 suspect obstetric unit at a tertiary care center. Another paper describing the dynamic triaging of asymptomatic COVID positive obstetric patients has been published in EHP, Evaluation in the Health Professions, where you can read more about it. The Nationwide Quality of Care Network in India launched the Community of Care Practice for Point of Care Quality Improvement in August 2020 as a learning platform and support network. They have since then leveraged this technology-based solution to connect to their national and state mentors, organizing 30 virtual sessions for clinical and QI mentoring in just last 3 months, thus amplifying their outreach. NQCN has also started an online course on point of care quality improvement, specially designed to recreate the experience of physical workshop on a state-of-art technology platform. And they are creating opportunities for experience sharing by South Asian QI practitioners through new online journals. It is my pleasure to introduce Professor Vikram Datta, who's the President of Nationwide Quality of Care Network India, and also the Director Professor of Pediatrics at the Lady Hardinge Medical College, New Delhi, to share in detail about these innovations. Over to you, Dr. Datta, for presenting your work in continuing the QI skill building, clinical and QI mentoring during the COVID-19 pandemic. We look forward to learning more about your innovations. Over to you, Dr. Datta.
Thank you so much, Dr. Deepti, for that kind introduction. Greetings to all participating countries as well as friends from WHO, UNICEF, my colleagues from Bangladesh. Good morning, good afternoon, and good evening to this international webinar on innovations in supporting QI at learning sites. I bring greetings from the Nationwide Quality of Care Network. We are a young organization which was started in 2017-18 in India. It's a voluntary organization of people who are interested to work for the upliftment of the cause of quality improvement in India. And as you can see, till date, we have achieved a target of nearly 1 million lives which have been touched by our endeavors, 550,000 deliveries which have been impacted, and 231 healthcare facilities which are being directly mentored for implementation of point of care quality improvement methodologies. We've got a large pool of 241 national QI coaches, and we directly assist the Government of India in leading the national mentoring group for the Laksh National Flagship Program of Labor Room Quality Improvement. Our pre-COVID area of operations were quite heterogeneous, as you can see from this slide. We started our operations and we tried to focus on the pre-service education, building up the capacity and the techniques of quality improvement in in-service personnel, ranging from the nurses, doctors, professionals, and professional organizations, working with various national health missions across 15 states of India, working with UN agencies and various development partners. And specifically, I would like to mention here our work with the frontline health professionals, where our work took us to the level of the primary health centers, sub-centers, and directly to the ASHA workers who are the first line in the healthcare delivery system in India. And like I mentioned previously, we are the technical partners to Government of India and the National Mentoring Group lead partner for the Lakshya program. Well, coming straight to the topic here, as you all know, the COVID pandemic was declared on 11th March 2020. This was followed by a national lockdown at a few hours' notice on 24th March. And this led over the months of April, May, and June, most of our quality improvement teams, which were till now involved in the quality improvement national flagship programs and UHC work, were now redeployed to take care of the COVID-related duties, just like it happened in other countries. Now, with this teams getting redeployed, in July and August, we thought that we should be connecting back to our teams, but there was no sign of the pandemic abating. And this was then that the Nationwide Quality of Care Network decided that it should survey the mentors and the facility using online tools. And what did we find in the online survey? This is a brief representative slide, which tells you that 65% or 2/3 of our mentors found difficulty in interacting with their QI teams. More than 90% of the team members and the mentors were using virtual communication, And more than 60% of the people were using online mentoring, and they felt that online mentoring was the future and is going to stay. Well, that led us to think of a technique or a digital platform to connect to our teams in a better manner, connect with the mentors in a better manner. And herein came the concept of the digital community of practice. The digital community of practice started with the development of the charter, the creation of an online state-of-art platform and the website, and it was very quickly, over a span of 6 weeks, inaugurated on 22nd August 2020. Now, here are few snapshots of the inaugural part of the online virtual point of care quality improvement communities of practice. And you can see on the extreme left, there's a letter of appreciation from the Honorable Union Minister of Health and Family Welfare, Dr. Harshvardhan ji. And he has emphatically requested the Nationwide Quality of Care Network to take forward the mission of supporting quality improvement across the various states of India, capitalizing on the digital platform. The inaugural session was addressed by none other than Professor V.K. Paul, member of the National Institute for Transforming India, the Niti Aayog, which is a part of Government of India think tank. And the expert session on QI at the inaugural was done by the ISQA CEO, Dr. Peter Lackman. This session was attended by dignitaries from partner agencies, governmental agencies, various UN agencies, and multiple participants. Now, this started the shift. Now, the shift happened into a virtual or a digital shift, which I'm going to be enlisting through means of certain photographs here. As you can see on the left side of my screen is the pre-COVID scenario, and on the right side is the new learning methodology. Well, before the COVID struck us, we had online on-site point of care quality improvement methodology, which was used as physical workshops. And during the COVID sessions, that is in these months following the launch of the digital communities of practice, we shifted to a e-based point of care quality improvement workshop, which was full 2 days workshop, followed up by follow-up sessions, a self-paced POKI online course, which has been launched on the learning management system. During the pre-COVID times, the mentoring techniques also underwent a shift from on-site QI mentoring to online clinical and QI mentoring, which is currently being piloted in 7 districts of Madhya Pradesh. And mind you, this is not only the neonatal care units, but also the labor rooms and the maternity OTs which are being mentored. And these are the remote tribal districts adjoining the Gujarat border of Madhya Pradesh. And this has been actively being done with the support of UNICEF India and UNICEF Madhya Pradesh. Our capacity building techniques also show a shift from capacity building, which was done online, direct physical capacity building, as you can see on the left side of the screen, to during COVID, online capacity building webinars and workshops, as you can see on the right side, a virtual workshop wherein the participant is directly focusing on the fishbone, which has been conducted as a part of the online capacity building session. The experience sharing techniques saw a shift as well. The physical experience sharing workshops were a norm during the pre-COVID sessions. But during the COVID sessions, the online experience sharings became the new normal for us. We focus a lot on our nurses' teaching and training techniques. And as you are aware, at NQCN and in India, and I'm sure in the Southeastern Asia, we all believe that nurses are the backbone for carrying out any quality improvement activity. Well, during the pre-COVID time, you can see snapshots of our nurses teaching, learning, training, mentoring activities. Well, this shifted during the COVID to nurses' online courses, e-poster competitions, online quizzes, nurses' online workshops, podcasts, and nurses' online conferences, which are recently being held for the nurses. Well, we always believe that whatever work has been done by our teams need to be showcased and shared with the larger global population. And that was the reason that during the pre-COVID times, our emphasis was on publishing in peer-reviewed journals. But this became slightly difficult because the structure and the formality associated and also the cost which was associated with the peer-reviewed journal could not be met at this time at such short notice. And there were a lot of learnings, day-to-day learnings related to COVID triaging, infection control practices, patients' respectful care, patient feedback, etc. And we promoted website publications in means of podcasts, blogs, and forums. And I'm happy to announce here the launch of 2 open access journals by the Nationwide Quality of Care Network. The first is the prestigious South Asia edition of the British medical journal Open Quality, which is specifically bringing out a South Asia edition to showcase quality improvement work from the Indian subcontinent, and the Journal of Healthcare Quality. Both of these, the article processing charges have been waived off. And anybody who's wanting to showcase their work into both of these journals, I extend the invitation to all the participating teams and to my colleagues from Bangladesh to showcase their work into both of these journals. Now, as you can see, this is a summary slide which tells you the spectrum of activities which were undertaken by the network over September, October, and November since the time of launch. And just to summarize, over the last quarter, that is September to December, we've conducted 86 online events, and more than 3,000 health workers have been engaged in these events. And you can see the spectrum of the events. Well, when I say 3,000, it means a lot for us. Why? Because since existence, as you would have recalled in my first slide, we had touched nearly 3,700 healthcare workers. And over the last 3 months, we have touched more than 3,000 healthcare workers. Therein, a strong advocacy for the use of the digital technology and its reach. Well, this is a slide which shows a histogram of the number of activities which have been conducted since the declaration of the pandemic till date. And you can see in the histogram the number of activities. Basically, if we look at the phases in the digital shift, the first was the phase of adaptation, where the COVID pandemic was declared, and we tried to reconnect with our teams by holding certain webinars, focusing on infection control practices for nurses, and holding some international webinars for our teams. And therein came the second phase of conceptualization, where the digital COP was conceptualized based on the survey which I just shared with you, and the digital COP was inaugurated on August 22nd. And the third phase, that is the current phase, is the phase of sustained intensive activity. And I'm happy to share here that in the last quarter of this year, activities for maternal and neonatal healthcare nurses are on our prime focus with the support of UN agencies and development partners. Now, briefly, I would just like to share with this August gathering the digital COP model. Well, the digital COP, or the communities of practice model, basically is a 4-layered structure. The innermost layer consists of a core and a ring of internal stakeholders. These are the various committees which are essential for maintaining the structure and running the communities of practice. This is followed by a layer 2, which is the communities of practice participants who make the community vibrant and alive. This is followed by an outer layer of external stakeholders, which consist of various development partners. And the last is a layer, which is the outermost layer, that is the digital platform, which supports the whole layer 1, layer 2, and layer 3 in the cyberspace. The operational mechanisms, if you look at in the center, is the digital communities of practice. This is the digital communities of practice. With continued stakeholder and partner engagement, the sustenance of the digital COP activity is maintained, and we take a lot of feedback and we continue to evolve and transform so that the digital COP does not become outdated. We've also kept certain key performance indicators from the start, which have been inbuilt into the system so that we keep a track of the performance of the communities of practice, because we don't want it to go the way many communities of practice go. And when the online shift happens, initially it generates a lot of interest, but later on people lose interest and they just die out. Well, COVID is here to stay for some time, and we need to keep our belts tightened. Well, these are the general trackers. And as you can see, we are monitoring in real time since launch the traffic over time, the top referring sites. And I'm happy to share here that our digital platform is having more than 71.5% new visitors. So it is generating a lot of interest in the visitor traffic. We are also doing some participant tracking, and this participant tracking is real-time registrant to attendee ratio, the proportion of participants who are returning to our repeat events, post-event engagement with the participants, and interest in future sessions. Besides this, we're also monitoring the number of questions which are being asked and the average duration of each interactive session, average number of comments on the blogs, and number of competitions connected per month. We are keeping some platform trackers also as KPIs. And these important platform trackers are the increment in the digital communities of practice visitors, the website hits per day and the average time spent, the number of activities and the domain specific activities, besides the number of members who've taken the membership of the communities of practice since launch. And you can see that there's been an increment of 51%, 17%, and 16% since launch. We're also tracking the subdomains, that is the forums, the blogs, etc. And for representative purpose, I'm just sharing a blog view activity over time since launch. And you can see how we are tracking it in real time. Now coming to the concluding part, the main advantages of using digital technology for supporting quality improvement, our experience from India is, and I would say that this is a preliminary experience. We have to evolve, and we are evolving, adapting, and changing. The preliminary experience is that it is cutting our cost to the tune of 70 to 75%. It has a greater reach. People from as far away as North America are joining this digital platform. It has a better return of investment, definitely. There's no doubt about it. It is an effective utilization of time. And it is having a minimal effect on primary caregiving, as people don't have to move away from their hospital floors. If they are not on duty, they don't have to come to the hospital to attend a physical session. They can do it from the comforts of their home. Well, this is the main advantages. Well, when I say the advantages, there are few challenges as well. The challenges related to the inputs are, and these are major challenges in a low and middle income country. And I'm sure my friends in Bangladesh also would be facing similar challenges. These are the challenges with internet bandwidth, availability of IT equipment and the functionality at the peripheral sites, issues related to the privacy, consent and ethical consent, and issues related to on-site coordination and maintaining the attention span. Certain other challenges related to the processes are, how do you build rapport with the team? Because now you are doing it online. Previously, you were doing it on site, where you were going and you had a face-to-face interaction. We don't get to assess the process flow in real time. And all my friends in quality improvement would know that's vital to assess the process flow. Looking at the data fidelity, we don't have access to the source documents. We just have to rely on the data which is presented to us. Well, we trust our teams, but definitely documentation and interpretation of the data is a big challenge. And lastly, online fatigue with the multiplicity of online activities which are being rolled out simultaneously. Finally, the lessons which we have learned amidst the pandemic is that the shift to digital teaching and training is essential to reinitiate and sustain quality improvement initiatives. Second, it can cost effectively showcase learning to a wider global audience. Just like I mentioned previously, it's led to a cost cutting by nearly 75%. However, a full-time technical team with knowledge and passion for quality improvement is an essential component, and it is the backbone of support for manning any digital platform and doing the coordination and making it work seamlessly. These e-learnings and mentoring techniques ideally should be tested for impact over the course of the next year, whether they really teach and train only, or they lead to improvements and on-ground improvements in the processes of care and the outcomes of care is something which we would like to evaluate. And lastly, they may be adapted for replication across global settings well beyond the pandemic time. And herein, I echo what Dr. Rajesh Mehta just said, that these digital platforms are here to stay well beyond the pandemic times. I express my heartfelt thanks and gratitude to the collaborative support of key partners who made this digital platform and this digital endeavor a reality in such short period of time for our country. And I hope that our collaboration will continue to grow and support the quality improvement revolution in India. Thank you so much.
Thank you, Vikram. You have clearly demonstrated that digital solutions can be applied, and you have shown that within few months of lockdowns, you were able to effectively put this in operation. But you are also correct that you have already built in some monitoring indicators, and you are open to actually doing evaluation on the way to see whether all these activities are leading to enhancement of knowledge, skills, and practices, improved practices, so that there is actually improvement in quality, which is delivered to women, newborn, and children in India. So my friends, we just heard a digital shift to the existing quality improvement work. India has done several other things which Deepti was saying, including investing in COVID-related quality improvement directly. So let us shift attention to Bangladesh now for knowing more on how the content of the quality improvement work has been adapted to suit the COVID pandemic issues. So I hand it over to Dr. Mohammad Ziaul Mateen, who is my friend from Dhaka, UNICEF. He is the health manager for maternal, newborn, child, and adolescent health, and is leading the quality improvement work with WHO within the QED network. Over to you, Zia bhai.
Thank you, Rajesh, and thank you for this nice introduction. Good afternoon, good evening, good morning. It's been a pleasure to be here and speak to you this August gathering here. Dr. Rajesh has already mentioned, I mean, how much this pandemic, the COVID-19 has impacted and to what extent, not only the country, but our personal life as well. Irrespective of where we are, I mean, the very rich country with a very efficient and good health infrastructure or health system, or the country like Bangladesh, with a relatively weaker health system, but fairly good infrastructure. But at the same time, the COVID-19 has taught us all a lot in terms of quickly adapting to this changing scenario, changing context, and making us more resilient to the emerging health challenges and the threat. And Bangladesh health system is no different to that. Particularly the knowledge and best practices from the facilities of QI learning districts help the health managers and the healthcare providers in Bangladesh, and all of us indeed, to quickly adapt to these emerging challenges. Already my previous presenter mentioned about these areas of infection prevention, triage, case management, and how quickly we adapted to these kind of changing scenario, applying the digital platform. The same thing happened in Bangladesh as well. And also finding some real life solutions from the experience of these learning districts for QI, particularly in Bangladesh, and the learning facilities, which particularly igniting the changes of actions at the facility level. Now, I would like to introduce Dr. Samiha Kaiser, who is working as a district QI coach in Patuakhali, one of a remote district in Bangladesh, under the technical guidance of National QI Learning Hub, which is based in National Institute of Preventive and Social Medicine, NIPSOM, under the Ministry of Health and Family Welfare. She will share her working experience in quality of care. So over to you, Samiha. Thank you.
That's great, Samia. Can you go to slide mode? Fantastic, thank you.
Thank you, Dr. Zia, for your insightful information. Good evening and good morning and good afternoon to you all. It's my pleasure to share the experience of Bangladesh with you all. And I know today's topic may bring up lots of questions, and I can assure you that I will address as many as I can in time. Let's walk through the journey of quality initiatives in Bangladesh. Quality Improvement Initiative started its journey through TQM program of DGHS with support from UNICEF and Zyka with more than 100 facilities. Quality improvement in Bangladesh got institutionalized in 2015 with establishment of Quality Improvement Secretariat at national level. Between 2016 and 2018, UNICEF supported the first learning district Kurigram with IMEN initiatives. The work in Kurigram became the model for QI and was scaled up to across 7 districts. In 2019, National Learning Hub for QI was established at NIPSOM, where I work as a QI coach in one of our learning districts. Recently, we have scaled up further to 19 districts out of total 64 in Bangladesh. In Kurigram, we achieved promising results following implementation of EMAN MNS standards in 5 facilities. Both provision and experience of care improved remarkably, leading to increased uptake of quality MNS services in all 5 facilities. And we were able to achieve a significant reduction in newborn deaths. So how Kurigram is functioning through these years? There are motivated and committed leadership QI teams, functioning QI committees and WIT teams, taking actions by themselves to resolve their problems through quality improvement cycles and action plans, continued on-site coaching and mentoring, clinical skill building through EMN clinical training of service providers, increased use of data for QI and measuring progress, continued learning and sharing among, within, and across the facilities. Here you can see the spread of our learning districts and learning facilities. In 4 years, we have gone from 1 district and 5 facilities to now working on improving quality of care in 90 facilities across 15 districts. Here's the quick glimpse of our work in last 1 year. We are supporting 28 facilities in 7 districts. We built clinical skills of around 800 healthcare providers by training them on MNC standards. We also trained nearly 1,000 healthcare providers on using quality improvement methods. We followed these trainings by 350 on-site support visits to help them use QI methods to improve care. Teams of these healthcare providers carried out 200 quality improvement projects. These projects aim at improving care around birth and care for small and sick newborns. So let's have a look on some results in improving care. In our 28 learning facilities, nearly 1,500 babies are born every month. Hypothermia is a common problem in newborns. Where we started work through National QI Learning Hub last year, many facilities were not measuring newborn temperature after birth. As measurement of the temperature improved, we found nearly 1/5 of these babies were hypothermic at hour after birth. This is nearly 300 babies being at risk every month. Quality improvement teams in these facilities work on improving skin-to-skin care, ambient temperature, use of warm linen, and gradually they decrease the hypothermia down to 5%. This was one of the processes that all our learning facilities were working on. There are many more QI projects that individual facilities and teams picked based on their needs. So let's have a look on another result. Many of these improvement projects work on improving provision of care, while some work on improving experience of care for clients. The chart here is from District Hospital, Molvi Bazar. The quality improvement team in this facility realized it took too long for the pregnant women and mothers in our patient department for an antenatal or postnatal checkup. They reduced this time from 4 hours to 1 hour and have sustained it since then. While working on reducing service time, they also measured client satisfaction using feedback counter with colored feedback slips. While the service time reduced over the next few months, they also saw the increase in the number of pregnant women and new mothers visiting their clinic. Many such success stories were being written every month across our learning facilities, while we were working on institutionalizing these efforts within the system early this year. So while we were working on our improving QI in 7 facilities, worldwide pandemic situation impacted on our healthcare delivery system at such extent that we had to face some untoward situations. As per statistics, childbirth in health facilities dropped by more than half. Also, immunization for childhood illnesses dropped by 50%. Antenatal care visits decreased. There was also a reduction in detection and management of common childhood illnesses like pneumonia. While deliveries and immunization services are now back to the pre-COVID numbers, other services in outpatient clinics are still recovering. This disruption in services was because of the message for everybody to stay home and stay safe, and the fear among the healthcare provider due to poor infection control practice and PPE supplies. Bangladesh government conducted an assessment to address the situation for better management. They found out some key issues like during the onset of COVID-19, facility preparedness wasn't up to the mark in terms of IPC. Triage and case management was also not up to the mark. The assessment findings in 120 district level facilities was that only 20% healthcare providers trained in IPC while 12% in case management. Over 15% facilities did not have the IPC and triage system in place. Guidelines and protocols and training modules were then developed by DGHS with support from development partner, including UNICEF. To overcome this situation, we did some adjustment with the QI activities to existing resources. We started by engaging with the healthcare providers on their need to be safe. We put our way behind the formal, structured, and informal relationships that had been our strength so far. We put our engagement with leaders and champions who had always been committed to their cause of improving quality. Initially, we focused on simple infection prevention measures that could be undertaken within available resources. Like many other places, we relied heavily on the webinar platforms and group messaging applications for training and for making available guidelines. For quality improvement reports, since we wanted quick results, we pre-designed many QI projects and let the facility teams pick up those. We also developed simple measurement indicators that could help IPC committees oversee progress. With the help of QI learning outcomes, we activated IPC committees in facilities and districts on the line of QI committees. QI coaches like me shifted our on-site support to building skills on IPC, helping the improvement in water, sanitation, hygiene. We started QI coaching that was relevant to the new reality. Clinical skill building now focused on how to improve MNCH practices during COVID. We also started building clinical skills on respiratory illnesses and standard of care. Many trainings were conducted through web as we worked with hospitals beyond our designated learning facilities. The terms in facilities started short duration projects on IPC and triage, in addition to the one on MNH quality of care. As we started getting results, we used WhatsApp, social media, and sharing webinar so that the facility staff could learn from their peers. In the meantime, Bangladesh government took the initiative on introducing national guidelines and training modules on IPC and case management, alongside poster videos on IPC, which was developed by DGHS with support of different partners, including UNICEF. We used digital platform using during the initial period of COVID-19 for very quick training for healthcare providers through Zoom. Continued monitoring through WhatsApp group networking. Then face-to-face training was done on site for more hands-on training on IPC and CM. During the training session, approximately 4,000 of service providers are trained. among the facilities of all over the districts of Bangladesh. Here are some facility provided feedback, how they were implementing their trainings through services. Bangladesh government also introduced new guidelines to improve MSCH services in COVID-19 situation, was developed and service providers and facility managers were also trained. And MSCH services delivery protocols are also developed in COVID situation. During initial months of COVID-19 and subsequent restrictions and lockdown, on-site coaching became very difficult. We use data reported through the national HMIS to track progress in improving QOC during this. We initiated data triangulation between on-site records that we as coaches has collected and data reported in DHIS2. UNICEF organized a series of training sessions for the coaches to help them master DHIS2 data analysis and review. We developed simple monitoring frameworks for IPC, triage, and COVID-19 related works, also for pediatric quality of care. We also started aligning QOC measurement with QED common network indicators and activated data review mechanism in facilities. Let's have a look on another project from Learning Facility Fulbari Health Complex, which focused on improving hand hygiene while entering the facility. Provision of basic facilities and guidance at entry made it convenient for the clients to wash hands. Measurement at reception counters by observation and feedback to those who had not washed their hands helped in quick improvement. Additional steps like provision of alcohol-based hand rubs allowed the facility to sustain the gains, and then soon they scaled it up to the other units in the hospital. In the learning facilities, some projects focused on building skills of staffs on using protective measures. In this example from Kurigram District Hospital, they used a structured observation-based checklist for PPE donning and doffing. Rapid deployment of new staffs who had no prior experiences resulted in poor compliance to safety measures. Simple solutions that worked are getting the list of new staffs in advance and organizing training session for them a day before they started work in the isolation ward. Ulapara Health Complex worked on improving screening on flu-like symptoms. While temperature measurement is commonly done in many hospitals and other institutions, it is important to screen all the visitors for the signs and symptoms, including the history of contact. The quality improvement team used a comprehensive checklist of signs, symptoms, and history of the clients coming to the hospital and slowly improved their screening to cover all the visitors. They realigned screening stations and ensured a linear pathway. They made it easy for the providers not to miss any clients. They directed those with flu-like symptoms to designated flu corner. These clients were then advised for testing and isolation. Many of our facilities had been working on ensuring preferred birth companions for women during childbirth. COVID brought a new challenge of having to prevent the infection spread among clients, their babies, providers, and birth companions. Shorishabari Upojila Health Complex worked on improving proper use of masks by birth companions. By observing and providing feedback, putting visual reminders, and by making spare masks available to those who need, they were able to ensure universal use of masks in labor room. We have newly introduced standards of improving care for children and young adolescents. During COVID, there has been increased focus on availability of oxygen in the facilities, leading to building necessary oxygen infrastructures and supplies, like central liquid medical oxygen, supply of oxygen concentrators, pulse oximeter, and cylinders, etc. This has created opportunity to integrate pediatric and newborn QOC standards, focusing on IPC and hypoxemia management. Guidelines, training modules, job aids, and monitoring tools developed for hypoxemia management, following pediatric and newborn QOC standards. Our work in the facilities now has therefore scaled up to include improved quality of care for sick and newborns for our pediatric clients. We are using our time-tested model for quality improvement and similar program designs to work on this emerging and important new area. As we move ahead, our plan to increase our focus on experience to care with continuing to work on improving provision of care. We want to establish quality improvement learning hubs in the regional medical colleges, and we scale up to more and more facilities. Monthly data quality check between DHIS2 system and facilities. At the National Learning Hub in NIPSOM, we were working on integrate quality improvement in the MPH academic curriculum and the academic research activities. So as a QI coach, all I can sum up to this, that we faced a lot of challenges due to COVID this year. And despite of all these odds, we again come up with new vision and plans for the nearest future. And learning through difficult situations helped us to perform better. Thank you all for your patience hearing.
So thank you, Samia, for very nicely telling us that how beautiful QI work was going on before COVID struck. And as soon as COVID was there, you had to make adjustments. And we saw that there was shift to accommodate the immediate needs of infection prevention, data management for COVID, masking, PPE use, hand washing, and same QI principles which were used for improving care for mothers newborns have been used to improve the practices. So that would lead to quality of care, certainly. And then you also started using the opportunity to strengthen newborn care in facilities and pediatric care in facilities. And you're already strengthening oxygen delivery systems, which is critical for pediatric care. So thank you for sharing those experiences. So over to Olive to then take us through question and answers. Thank you so much.
Thank you so much, Rajesh. And thank you, Dr. Vikram and Dr. Samia, for sharing with us these fantastic presentations. We have some questions in the chat box, some very specific questions. Firstly, for Dr. Vikram, if there are any questions for Dr. Samia, please share them in the chat box with us as well. So firstly, Dr. Vikram, there was many advantages shared from this enhancement of the digital approach in India during COVID-19. And so the statement that better return for investment, we will require evidence of the impact on the knowledge transfer and on practice change. Do you have evidence thus far towards that, for further support of this digital forum?
Okay, I think that's an excellent question, Olive, and I should congratulate the person who posed this question. And definitely, as I mentioned in the concluding parts of my presentation, the formal impact assessment will become one of the mainstays of our work over 2021. It's just been 3 months since this digital shift has been actively, accelerated into the present form. The learnings are coming in, they are initial learnings, we are evolving and we are also learning at the same time. But at the same period of time, like I showed you the trackers and the key performance indicators, like the platform indicators, the user-based indicators, the digital, subdomain indicators, these are very much being tracked in real time. And once we have sufficient data set, we are going to be analyzing them over the early first quarter of the next year. That is one. Now coming to the translation into quality improvement projects, I would just like to mention here that our work which takes us to Madhya Pradesh, which is the state with a large burden of neonatal and maternal mortality. And I think most of you know that Madhya Pradesh is sharing borders with multiple states, the largest state in India. So 7 tribal districts. So this district and sub-district facilities are completing 7 quality improvement projects which are due for submission in December after 2 months of intensive online clinical as well as quality improvement mentorings. Well, some of the projects have not been successful, but we are documenting the challenges and therein the impact would be assessed. And I'm sure we will come up with the meaningful data in the subsequent sessions with WHO headquarters and the larger network.
Thank you so much, Dr. Vikram. That's very clear. Thank you. There's a lot of thanks and appreciation in the chat box for these excellent presentations. So just to highlight that for you. And also now, Dr. Samia, we have a question, okay? There's one colleague, Nafisa Intam, is asking, health providers such as doctors and nurses were given training, but I wonder how community health workers were included in QI training. Do you have an example of that from Bangladesh? Oh, you're on mute, Dr. Samia. Thank you.
Okay. Thank you for the question. Okay. The healthcare, community health workers and health, they were working on NGO provided awareness training at the community level, basically. They helped them to work on their skills and to get to know about the about COVID and the transmission and overall. And basically, our efforts focus on the facility level care presently, because most of the cases is coming through the facility first, then they are dealt with the facility first. Then we plan to expand our community health workers as we gain some strength on it first. Then they will be included with this network for the QI training.
Okay.
So, Dr. Deepti, do you have any idea for from India if ASHAs have been trained, the village level workers have been trained using digital format?
I think they have been reached more through the mobile, platform rather than getting them on a online web platform. And a lot of messages, yes, are being transmitted through the available mobile apps, which already used by the frontline workers. You know that some of the workers are also ANMs have been provided tablets for their routine work.
They have handheld advice already.
They have handheld tablets which they're using. So I think that is one, way that they can be reached out.
Some form of digital health can be used to reach through community health workers. There are other examples also. So that is possible. Vikram Atnafu, my colleague from UNICEF Rosa, has a good suggestion for you. Can you compare the traditional way which we used to do and the digital way now? Can you design something to also do a comparative assessment, whether it leads to the desired results equally or less equally? So for future, maybe you can consider that as a good suggestion. Thank you, Olive.
Yeah, very good, Rajesh. Thanks for highlighting that. And thank you, Atnafu. We've one final question. We're just coming to time. So can we ask a little bit about, there's a question about cost effectiveness, I guess, of the digital platform, Dr. Vikram, that there's a lot of partners and donors in support, which is fantastic. But for the continuation of such a platform, could you explain a little bit about cost and cost effectiveness?
Okay, so basically, like I mentioned, the main cost is a one-time cost of setting up the digital platform. There is a recurring cost to the subscriptions to the web-based communication platforms like Zoom, WebEx, etc. And that is a sizable cost, because once you have platforms which are able to cater to 1,000+, like recently we had a meeting where the nurses workshops as well as conference was held, and we had 1,250 registrations. So we had to have a 1,000+, web-based platform that comes to a sizable chunk of the part. Now the hardware is a one-time investment. We are doubling up our office, hardware to be substituted for the COP hardware. We don't require real-time hardware. Another very important thing is the software related to the emails, and the communication tools. That is the Google Suites and the YAM trackings, sending in real time the communication tracking, etc. to all the participants and trying to reach with them. Then another very important is the feedback tools and the softwares for analysis, like the Survey Monkey, the Mentimeter, etc., which have to be taken. So these are, and apart from this, the technology team. the cost of the salaries, which we are very grateful to WHO for supporting us.
Okay.
And that is something which takes the bulk of the costing for the technology. And rest is effort, which is unmeasured and unquantifiable in terms of, remuneration.
Yes, indeed, indeed. Okay, very succinct. Thank you so much. I'm going to have to say thank you so very much. We have come to time. In fact, we're probably a minute over or so, but this is so interesting. Thank you so very much. So Dr. Rajesh, Dr. Zia, Dr. Vikram, Dr. Samia, and Dr. Deepti, thank you. Really, this has been a fantastically interesting webinar. As I said, we are going to share it on the website with the recording and with the slides. Okay, so thank you to everybody. To continue discussion, there's a link here to the series and to the community of practice. If you want to pose more questions to the speakers today, and you'll find it all on the website. So that's all for me. Thank you so very much. And everybody take care, stay safe.